only mode.
Good morning, everyone. This is Andy Dwyer with Fight CRC and University of Colorado with our October webinar series, supported through our Research Advocacy and Training Support Program with Fight CRC. I want to welcome all of the RATs as well as all of our Fight CRC advocates, survivors, supporters who have joined us this morning. So we're very excited to have a really awesome discussion with Dr. Chris Lieu from here at University of Colorado to talk about precision medicine and immunotherapy, and specifically as we ramp up and we're getting ready for our research advocates to join us in Denver in 2 weeks, November 5th and 6th. We wanted to ensure that we had really good exposure of a lot of the topics and a lot of the timely information that's being provided. So we have a short time today for about 20 minutes of presentation from Dr. Lieu, and then going into a really heavy question and answer session. We have about 75, 80 people registered for today, but if our numbers don't peak over 25 or 30, we'll be able to open up the questions at the end for more of a live Q&A session. But if we get over the 30, we probably will just leave it to the chat feature. So during Dr. Lieu's presentation, if you can go ahead and please type all of your questions that are coming up real time, either Kevin will facilitate, or if we don't get too large, we might be able to open up the lines. So we're very excited to have Dr. Lieu, who has been one of the key members to help really bring through in-kind support at the university leadership to host the RATS training. And we're very excited to have him really help us open up one of the discussions this morning. And so he is an associate professor at the Lieu here at university, specifically working in the GI malignancies program, and is a true leader in the field, serving on the CRC task force, as well as a number of other professional societies, and has done a lot in the area of looking also at young people and the diagnosis of colorectal cancer. So we're really excited to have him as part of this program. I do want to send a special thanks to Kemi and Michael and our team for helping move this forward and really making sure that we're all queued up for the morning. So with that, Dr. Lieu, I'm going to pass it off for your presentation. Thank you for joining us.
Great. Thank you so much, Andy, and certainly thank you all for taking time out of your day to talk about precision medicine and immunotherapy. And thanks again to Fight CRC for setting all this up and for the opportunity to have this webinar. Super excited about RATS, about having everybody come to Denver. And over the next 20 minutes, this is the agenda that we're going to talk about, and it'll be a little bit more colorectal cancer focused, obviously because that's the arena in which I work in. But obviously anything that we talk about regarding biomarkers, whether it's for CRC, lung cancer, or any cancer, a lot of these concepts are certainly translatable between disease groups, especially when we talk about biomarkers in general and immunotherapy. And obviously trying to think about going over everything that you possibly need to know regarding biomarkers and immunotherapy in just 20 minutes would be pretty ambitious. And I'm really just want to start introducing you to concepts that you might be hearing about, particularly when you start sitting on task forces and when you start talking to doctors about their research. I want you to have an idea of the language that people use. What are the general concepts when people talk about personalized medicine or immunotherapy, just to kind of get a start, and then obviously we'll leave a lot of time for questions. The first part of this talk is actually a presentation that I did in conjunction with Amgen, and it's a patient presentation that we discussed that we did when we discussed with patients about what they should do regarding their biomarker. What will make this a little bit more fun is that I was a little bit restricted in terms of what I could say during that presentation. Those breaks are now taken completely off. So I'll be able to talk a little bit more in detail about that. But I want to really get behind the science behind biomarkers. Why do we what is the data, the clinical data, the research data to suggest that biomarkers may or may not be helpful? And I want to talk about that. And then I'm going to briefly overview this concept of immunotherapy because it is so hot, both in research and in the press as well. So what we know is that unlike cancer medicine 15, 20 years ago, we know that personalized medicine is advancing, and that's essentially what anybody means when they talk about biomarkers. And this idea of trying to tailor a patient's therapy more towards what makes their tumor unique is really what we're going for. In the 1980s, 1990s, the idea was a one-size-fits-all type treatment for any cancer. So if you have this type of cancer because it originated in the skin, in the colon, in the lung, we're all going to use the same chemotherapy. We're going to act like all 100 patients with the so-called same disease, lung cancer or colon cancer, they're just going to get all the same treatment. So we shouldn't be too surprised when some of that medicine works for some patients and it doesn't work at all for other patients. And so this idea of trying to personalize medical treatment has really come into play over the last decade in particular. And the idea is to be able to identify patients who may benefit from a particular treatment or who may actually not receive any benefit from a particular treatment. And that's obviously important to know. So whenever we create a treatment plan for any patient with cancer, we want to make sure that, one, it's multidisciplinary. And so one of the things that I think I see most major cancer centers doing is starting to work together. Nobody kind of lives in their own silo. So we want surgeons talking to radiation doctors who are also talking to medical oncologists like myself so that we can formulate a good personalized treatment plan, even irrespective of their biomarker, that they're getting a full kind of comprehensive look at their cancer from multiple different angles. Chemotherapy is obviously the most common treatment that's used for cancer, but we're starting to see more and more targeted therapies, drugs that are kind of more like smart bombs. They kind of hit a particular mutation or a particular target, hopefully more specific for the cancer than your healthy normal tissue. And those are the most common treatments for metastatic colorectal cancer, but for cancer in general. Chemotherapy is a type of cancer treatment that just works kind of indiscriminately. It just works by killing rapidly dividing cells. So maybe we hit the target, maybe we hurt some normal tissues, and that's always been the problem with chemotherapy. A targeted therapy is obviously a cancer treatment that works by targeting specific genes or proteins that we think are altered in cancer cells. And sometimes we use it alone, and sometimes we use these targeted therapies in conjunction with chemotherapy. So when we talk about biomarkers, that's essentially short for biological markers. They're biological molecules that are found either in the blood, in the body fluids, or the tissues that can provide some more specific information about a tumor. And when a biomarker testing is done, the result of that biomarker may indicate that a cell function is normal or abnormal. It may provide some insight in terms of what is the likely outcome for the cancer if it's left untreated? And what we mean by that is, what is the prognosis? Biomarkers can sometimes predict the likelihood of a cancer's response to a specific treatment plan. That's what we really want. And obviously, the most important thing about any biomarker that we test, whether it's standard of care or whether that's in the context of a clinical trial, we want that biomarker to inform the patient and the doctor in regards to their treatment planning, and that's obviously where we want to get to and what's most important. So when we talk about biomarker testing, if we take patients, in this example, we're using metastatic colorectal cancer. So if we have patients with metastatic colorectal cancer, we do a biomarker test. If we say that a patient is biomarker negative, a lot of times what we mean by that is that there's no mutation detected. And if you hear doctors talk about, well, this biomarker is wild type or this gene is wild type, it means that the gene is not mutated and typically represents that that particular biomarker or that particular gene is normally functioning. If we say that a biomarker or a gene is biomarker positive, it usually means that there's a mutation that we've detected or an alteration that we've detected that may suggest that the cancer is using that gene to drive its growth. So it's possible that that particular gene may be very important, and that's what we mean by saying, okay, well, this patient is biomarker positive. When you look at a biomarker test results, and again, the example here is for metastatic colorectal cancer, if we say that a gene is mutant, and in this case, there are two very important biomarkers for metastatic colorectal cancer, RAS, which includes the genes KRAS and NRAS, as well as RAF. In this case, the gene is called BRAF. Why this is important is because about half of the patients with metastatic colorectal cancer will have a mutation in RAS. Why this biomarker is so important is because if there's a mutation in RAS, we know that there's a class of drugs that will not work for those patients with metastatic colorectal cancer. And I'm actually going to show you the clinical trial data. What this means is that the patients that receive the drug who are RAS mutant will get the side effects of the drug, but they will be very, very unlikely to receive any clinical benefit. It won't affect their tumor. A BRAF mutation, I'll show you data on this as well. It's a minority of the patients with metastatic colorectal cancer, about 5 to 10%, but we know that this is a poor prognostic marker. And what we mean by that is simply that the cancer seems to be more aggressive and the overall survival is shortened in these patients that have this particular mutation. And I'll show you clinical trial data on that as well. So to wrap up kind of this first segment, we believe that knowing a patient's biomarker status can be important in terms of what makes their tumor unique, and we're just encouraging patients to start asking their doctors about this. Will my tumor be tested for biomarkers, and how will that impact their care? And so we've encouraged patients to obviously speak with their doctor. In terms of advocacy, this means that you're going to start questioning us about the importance of a particular biomarker, what the science is behind that, and why that might be important to our patients. And your perspective is going to be critical for that. And so we're obviously encouraging this dialogue, not only in the clinic, but outside of the clinic as well. Okay, so I told you about a couple of genes. In particular, we've talked about RAS for colorectal cancer, and we've talked about RAF for colorectal cancer. Well, why do we bring this up? What's the science behind this? And these are some of the graphs that you're going to start to see when you're sitting in these meetings. So physicians like me are going to present a clinical trial idea, and these are the kind of curves that we're going to show you. So what is the data behind testing for this gene RAS in patients with metastatic colorectal cancer? And I'm showing you the data here. So this is a New England Journal of Medicine paper from 2008 showing patients that were treated who had colorectal cancer. They were treated with this drug called cetuximab, which is an EGFR inhibitor, that stands for epidermal growth factor receptor inhibitor, or they were randomized to receive best supportive care only. What you see here, the graph on the left, and I don't know if you guys can see my arrow, but I'm kind of circling it here. This graph on the left shows patients that have the mutated KRAS gene. And what you see here is of those patients that received the drug, they did no better than those patients receiving best supportive care. What this means is that they probably had a rash from the drug, they may have had fatigue, they may have had diarrhea, but they didn't receive any anti-tumor effect at all, which means that if they were RAS mutant, they weren't going to receive benefit from the drug. And you can see that all of the benefit here was seen in patients with wild-type KRAS. The patients that received the drug that had wild-type KRAS or were biomarker negative, if you will, they lived longer than those patients receiving best supportive care, and that's what this graph is showing you. I also talked about BRAF, BRAF, this mutation in colorectal cancer, and we talked about how this affects only 5 to 10% of the patients with colorectal cancer. But what the graph on the left shows you is that they're more likely to have brain mets, lymph node metastases, peritoneal mets. What this means is essentially tumors that are in the abdomen. This is a more aggressive histology. We very rarely see patients with colorectal cancer get their tumors going to the brain. But with these patients that are BRAF mutation positive, we see more brain metastases. This is obviously something very concerning to us. What you see also on the graph on the right is that if these patients have this BRAF mutation, they're also more likely to die from their disease earlier. And so this is important in terms of what we call a prognostic marker. How well is the patient going to do with their disease? And I want to make the distinction between a predictive and a prognostic marker. A predictive marker is like the RAS gene, the graph that I just showed you. We can predict whether the drug is not going to work. In terms of BRAF, we can tell you whether or not the disease is going to be more aggressive, and that's prognostic. What we don't know is whether we can truly target BRAF mutant colorectal cancer, and there's actually a trial going on now within the United States, all over the United States, looking for these patients because we have a tailored therapy for these patients with this particular mutation. We just don't know yet if it's going to work, but I can tell you that the preliminary data is certainly promising. I also want to describe this mutation in another disease called melanoma. So we know that about half of patients with melanoma have this mutation in BRAF. And so this is the same mutation that we see in colorectal cancer, is the same mutation that we see in melanoma. But the difference is that in melanoma, it's about half of the patients have this mutation. Why this is important is because we have a drug that can target this mutation called vemurafenib. And the results, and you guys may have seen this picture before, can be very, very profound. So believe it or not, picture A and picture B are actually the same patient, and this is just after 6 weeks of taking this drug. And you can see that the change in this patient is absolutely dramatic, and it's simply by giving a patient a pill that targets their specific mutation. And why I bring this up as an example is that it's really the proof of principle that you can actually target these mutations with a drug, and sometimes the results are dramatic. I also bring this up as an example because we tried this same drug in patients with colorectal cancer, and only 1 out of 20 patients actually had a response, which means the same mutation that we see in 2 different cancers respond very differently to the same treatment, a drug that targets BRAF. So our trial, where we're targeting BRAF in colorectal cancer, actually is a combination of 3 drugs, not just a single drug alone. Because it works in melanoma, it does not work in metastatic colorectal cancer. A very important point to remember, that just because we see activity in one disease type doesn't mean that we're going to see activity in every other disease type. Okay, I'm going to switch gears and just talk very briefly about immunotherapy, because you are going to see a ton of concepts looking at immunotherapy moving forward. And the idea of the immune system in cancer is that cancer is essentially a failure of your immune system to adequately recognize something that shouldn't be there, and the failure of your immune system to kill that tumor. And we know that there are actually checkpoints in our immune system that tell our immune system, okay, it's time to get going, you got to go, you got to fight. A good example of this is the flu. When you have the flu virus, your immune system knows that it's supposed to turn on, and there are a bunch of signals there that tell it to turn on. With cancer, it's the exact opposite. The cancer is always telling your immune system, nothing to see here, I'm perfectly fine, do not kill me. And we know that part of the inhibition of your immune system is through this pathway called the PD-1, PD-L1 pathway. And when T cells, which are your immune cells, express PD-1, and your tumor cells express PD-L1, the receptor, they make a connection. When that PD-1 binds to PD-L1, it tells your immune system, it tells your T cells to turn off. It's an inhibitory signal. So when that connection is made, the immune system shuts down. The tumor cells develop a lot of PD-L1 receptors to turn the immune system off. The difference now is that in 2015, we actually have FDA-approved drugs which can bind up these receptors. They can bind PD-1, they can bind up PD-L1. And what happens when we block those receptors is that sometimes the immune system can then start to become activated, recognize the cancer, and start fighting it. And indeed, there are 2 FDA-approved antibodies, nivolumab and pembrolizumab, very difficult words to say, that are now approved for melanoma and for lung cancer as well. I do want to bring this up in terms of colorectal cancer, because we've actually tried these drugs in patients with colorectal cancer, and the results haven't been as profound as what we see in lung cancer or skin cancer. And so I'm bringing up this idea of, again, the fact that some therapies work for some cancers, but the same therapies may not work for other cancers. So what we also know is that there's about 5% of patients with colorectal cancer that have a deficiency in mismatch repair. And what happens when you have a deficiency in mismatch repair is that your tumors, instead of a tumor having 30 to 60 mutations, which is what a typical colorectal cancer has, patients with mismatch repair deficiency, they don't have 30 to 60 mutations. They actually have 1,500 plus mutations in their tumor. Why this is important is because when you have this many mutations in a tumor, you may actually your immune system starts to recognize that, wow, this is something that's really messed up. There's like thousands of mutations in this tumor. And when we look at these tumors under a microscope, we can actually see lymphocytes, these T cells, actually within the cancer itself, because it's so deranged. And again, it's a minority of patients, but it's something where we already know the immune system is somewhat activated. So in this 5% of patients, can we use the same immunotherapy that has been so effective in skin cancer and lung cancer? And here's the data. The bars in red are your typical 95% of patients with colorectal cancer, the 30 to 60 mutations. The bars in green are the patients with colorectal cancer that have the 1,500 mutations in colorectal cancer. So this is the 5% of patients that have mismatch repair deficiency. And what you're looking at is the change in tumor size. And as you can see, those patients that are mismatch repair deficient, that have a ton of mutations in their tumor, they're receiving a ton of benefit from this drug, whereas the patients that have intact mismatch repair mechanism, those patients don't receive any benefit from the drug. And so to that point, if you have mismatch repair deficient colorectal cancer, your response rate was 62%. This is near, sometimes better than what we see with standard of care chemotherapy in the frontline setting. And this is with an immunotherapy, a drug that's typically very well tolerated. Whereas if you have a mismatch repair proficient cancer, and again, this is 95% of patients with colorectal cancer, the response rate was actually 0%. And the take-home point here is essentially that I want you to know that these immunotherapies are currently out there, that they're currently being developed, but again, they may only work in a subset of patients. And some of the proposals that you're going to see when you sit in these meetings are trying to find the best patients to pair with this immunotherapy. And in some cases, it may only be a minority of patients. All right, so I'm going to wrap this up. We're going to open it up for questions here. But in summary, biomarker testing is becoming more common, and every single clinical trial that you see moving forward is probably going to have some type of biomarker component to it. Biomarkers typically require biopsies of the tumor, but you're also going to start hearing about technologies where biomarkers can be measured in the blood. We call this a liquid biopsy. How easy would it be to be able to draw a vial of blood and be able to test biomarkers? And we're starting to see companies emerge and technologies emerge that allow us to do that. We are certainly limited by what we don't know about cancer biology. Biomarkers aren't perfect. I showed you a great example of melanoma and a BRAF mutant melanoma treated with a BRAF mutant inhibitor showing dramatic effects. I've also told you that that same inhibitor is not FDA approved for colorectal cancer in patients that have the BRAF mutation because it doesn't work. So we need to devise a better strategy for colorectal cancer because colorectal cancer and melanoma are certainly different. And immunotherapies are emerging as effective treatment options, but they don't work for all tumors. And this is an important point because as researchers, we need to find better ways to pair our immunotherapies, maybe as a combination of drugs, so that maybe they work for a greater percentage of our population. Before I open up the questions, I will tell you that this is an extraordinarily exciting program. I've sat in meetings with Nancy Roach. I don't know if she's on the call or not, but her input has been extraordinarily valuable. And I encourage you to be bold in these meetings to speak up because whereas we, the physicians and researchers, may be experts in regards to biomarkers, may be experts in regards to immunotherapy or clinical trial design, you guys are going to be our experts for patients. There's a very vast minority of doctors that can truly understand what the patient's interests truly are, what the patient's anxieties, fears are. And if we talk about a clinical trial where we just draw a tube of blood and that's where the biomarker is going to be, then as a patient, you may be able to give us perspective in terms of what they might think about that or the risks. If we talk about a biomarker testing where we have to take out half of your liver and maybe the biomarker testing isn't really that critical to the clinical trial, you guys need to speak up and say, wait a second, as a patient, this sounds ridiculous. We need to hear this. Certainly, we've obviously relied on Nancy to tell us these things. We're going to rely on you to tell us these things, to tell us where we've lost sight, where our blind spots are, and you guys are going to be able to fill that, and that's going to be critical. So with that, I'll open it up to questions, and I'll turn it over, I think, to Kevin or to Andy to moderate that.
Awesome. Thank you so much, Dr. Lieu. This has been very informative, and we've had a lot of really great questions come in. So I'm going to go ahead and ask a couple of questions that have been typed in, but I also want to let attendees know that if they would like to ask a question out loud, if they would use the raise their hand feature. So if you click raise your hand, I'll then be able to go in and unmute you so that you can ask your question. But I will go ahead and start asking a few that we've received. They're really great, important distinctions. So I'll start with one around the testing. So Nancy's actually asking further clarification on are RAS and RAF the only biomarkers that a patient should be tested for? And then what about MSI status related to Lynch syndrome?
Yeah, that's a great question. I think I'm getting a little bit of an echo, so if you guys can mute your phones. So RAS and RAF are probably the two most commonly tested biomarkers. Microsatellite instability testing, this is the mismatch repair deficiency that we discussed when we talked about immunotherapy, is also going to come out in the guidelines in terms of something that should be reflexively tested for. What I mean by reflexively tested for is that these tests should be done without anybody ordering them. They should just be done as standard of care. The reason why is because it's important in regards to not only what your risk of having a cancer recur is if you're stage 1, 2, or 3, but it also opens up the possibility of doing immunotherapy trials, and that's part of the reason why this testing is becoming more important. RAS is one that is absolutely required. The guidelines are going to come out that RAF should be tested. Right now, there's a percentage of practices that don't test at all for RAF because we can't necessarily act on it. That's what we mean by predictive versus prognostic. Right now, RAF is prognostic, which means that we know our patients do worse. We just don't know if we can do anything to modulate that or modify it. But the guidelines are going to come out suggesting that RAF should be tested on all patients. Another one that I'll bring up, just because it's for colorectal cancer, is that for early stage colorectal cancer, PIK3CA should be tested, another mutation. What you're going to find is that more and more academic centers are actually not just testing for RAS only or RAF only or MSI only. What they're sending off is actually a panel of mutations. It may not be able to necessarily inform what they're going to do right at that moment, but it does bring up this idea of testing for mutations kind of in bulk. And therefore, if we need to look for a clinical trial, maybe we can better direct our patients to a clinical trial that may benefit them. MSI testing should be done on all patients. And that's kind of where we are right now. But you're going to see these panels continue to grow. We're testing more and more mutations, and by doing so, we're going to learn more, but maybe be able to better direct our patients.
Awesome. Thank you so much. So this question's from Paul. So can you explain the link between microsatellite instability and mismatch repair? So MMR and MSI.
So there are, so the question is to kind of differentiate between mismatch repair deficiency and microsatellite testing, is that correct?
Yes, so when you see the MSI reference versus the MMR reference.
Yeah, so I think to kind of keep things, you know, in general terms, if you see mismatch repair deficiency or microsatellite instability high, so you'll see this written as MSI-high or H. You'll also see MMR deficiency, mismatch repair deficiency. I would use those essentially interchangeably. One of the things that you may kind of see in terms of terminology is something called Lynch syndrome, because a lot of mismatch repair deficiency falls under a genetic syndrome associated with colorectal cancer called mismatch repair deficiency. All patients with Lynch syndrome have mismatch repair deficiency. They are also all MSI high. It is possible to be MSI high, microsatellite instability high, without having Lynch, but all patients with Lynch syndrome are at microsatellite instability high. But for the purposes of clinical trials or biomarker testing, you can kind of look at MSI high, microsatellite instability high, and mismatch repair deficiency, MMR deficiency, as equivalent things.
Great. So can you talk a little bit more about negative versus prognostic biomarkers? I know that you talked about that a little bit. Allison is asking, I understand that wild type is not mutated and positive is with mutation. You mentioned wild type KRAS and BRAF. How is that possible?
And sorry, the last part was, I think, the part that I didn't quite capture.
Sure. What the text says is you mentioned wild type KRAS and BRAF. How is that possible to have wild type of those?
Okay, so we do see KRAS mutations or RAS mutations in about half of the patients with metastatic colorectal cancer, which means that half of the patients don't have a mutation in KRAS. They may have mutations in other genes, but the RAS gene is not been altered in any way, at least by any way that we can detect. So there are, a handful of patients, and this probably encompasses about 35 to 40% of patients that have completely normal KRAS and BRAF. What this means is that the cancer most likely developed utilizing other mutations or other growth factor pathways. Conversely, if a patient does have a RAS mutation or does have a RAF mutation, it means that at some point in the development of that cancer, that gene became abnormal. And what that means is that the cancer may be dependent on that pathway for its continued growth. And of course, that's something that we're obviously still trying to look into.
Thank you. So as far as mutant BRAF and then that being particularly or potentially common in younger patients or thinking about early onset colorectal cancer, how do those mutations potentially differ?
So it's interesting. In terms of BRAF mutations, we typically think about them as being more positive in our older population than in our younger population. Having said that, I think a lot of clinicians would agree that the cancer that we see in younger patients can sometimes be extremely aggressive. And so, being BRAF wild type doesn't necessarily always mean that your cancer is not going to be aggressive. Conversely, I have a handful of BRAF mutant patients that have done great for years. So we're talking still more in generalities or in trends. But in terms of younger patients with colorectal cancer, I, along with actually a lot of people across the country, are actually doing more profiling, more biomarker testing for in our young patients with colorectal cancer, because we're trying to find out what in the world happened where, I'm treating a 17-year-old with colorectal cancer. What in the world happened in my 17-year-old with colorectal cancer for that cancer to develop and become quite aggressive? And that, unfortunately, this is kind of where science meets what we don't fully quite know or understand, but we're trying to elucidate right now.
So Yasmin's asking this question, how would a patient know if they have had biomarker testing and can it be easily requested? What is the message that we need to carry forward about that?
Absolutely. So it's a great question. The message that we have to carry forward to our patients is to start that dialogue with their doctor. And it's always been kind of like this idea that cancer is this black box and whatever my doctor says is what should go. Those days are over, and they should be over. The idea of a patient having a very informed dialogue with their doctor is absolutely what should happen in every single stage of their cancer. And so what I've been encouraging all patients to do is actually go up to their doctor and said, has biomarker testing been done on my tumor? If the answer is yes, then the next question is, how will that impact my treatment? And the answer may be, yes, it will impact your treatment this way, or no, it won't impact your treatment, this is why. If the answer is no, biomarker testing hasn't been done on my tumor, the next question should be, well, will it be tested, and can I request that? And the answer should almost, universally at this point, be some form of yes, especially when it comes to colorectal cancer. And the other question would be, how will biomarker testing be performed? Like I said, most of the time we can do biomarker testing on tumor that's already been removed. In rare instances, it may require a repeat biopsy. In some instances now, we're going to start talking about drawing blood, but I'm going to make that caveat by saying, boy, that's still experimental in terms of biomarker testing in the blood, but we're going to start seeing that more and more, and you're going to start seeing clinical trials utilizing this technology starting now.
So talking about biomarkers as it relates to Lynch syndrome, so Winora is asking, as you study more about biomarkers, how important are the Lynch syndrome patients in that subset? And this is important to her because her family has greatly impacted by this. Her grandfather passed away at an early age, and she was diagnosed at an early age, as was her brother. So how are those Lynch syndrome patients being incorporated into these studies about biomarkers?
Yeah, so there's been a lot of focus on Lynch syndrome, and there will be over the next couple of years based on very, very promising data that was presented at the ASCO annual meeting regarding immunotherapy and in patients with mismatch repair deficiency. So in terms of the interest in patients with Lynch syndrome that have metastatic colorectal cancer or even early stage colorectal cancer, people are trying to design trials now treating patients with immunotherapy. Those trials are actually ongoing right now. But in terms of biomarker testing, it doesn't necessarily change whether you're Lynch syndrome or not. The same biomarkers that we would test in a patient that didn't have Lynch syndrome are the same biomarkers that should be tested in a patient that does have Lynch syndrome. So it doesn't necessarily modify what we should be testing for. It's just that everybody's looking for these patients because well, because of the data that immunotherapy could be effective or at least more effective in this subset of the population.
Thank you. So I'll wait another couple of minutes to see if any questions come through. So the audience, please feel free to use the question feature to type anything in, or if you would like to raise your hand, I can unmute you and you can ask your question over the phone. So I just wanted to, kind of talk a little bit more about, thinking about these improved therapies for melanoma and lung cancer and looking at the immunotherapies. Is there any sort of light that's been shed on why these types of therapies are not working for colorectal cancer and why these are different?
Yeah, absolutely, and that's the that's the key question of the hour. Interestingly, for BRAF mutant melanoma, you can target BRAF, and that drug does work as a single agent. What we know is that there's a feedback mechanism in melanoma where actually a combination of two targeted drugs is even more effective because it can shut down the feedback mechanism. Our body's pretty amazing because if you cut down one growth factor pathway, a lot of times the tumor will find a completely other way to increase its growth. What's interesting about colorectal cancer, so again, same mutation, exactly the same mutation that we see in melanoma we can find in colorectal cancer, albeit in a minority of patients. The feedback mechanism is completely different, which means that melanoma, kind of finds a way around the BRAF inhibitor in one way, but for colorectal cancer, it actually finds a way to become resistant to the drug very quickly in a completely different way. And so Scott Kopetz down at MD Anderson actually initiated a trial that's obviously nationwide now, where we actually utilized the BRAF inhibitor, vemurafenib, with an EGFR inhibitor, cetuximab or panitumumab, and we're combining that with chemotherapy. And so what's amazing is that you can look at the same mutation in two different tumors, but the resistance mechanisms are different. And that's what makes the two tumors different. And so just because a biomarker is positive in one cancer does not necessarily mean it's going to work for all other cancers.
Thank you. Andy, you had a question. I unmuted your line.
Sure. So Chris, thank you. This is awesome. I think, one of the things that that I know that we have here in Colorado, Ohio State, as well as I think University of New Mexico, MD Anderson, and several other groups, well, and of course with Moffitt Cancer Center being the lead. And I think it's really exciting for advocates and folks to know. I think you talked a little bit about, tumor and then biospecimen banking, and then, the opportunities for collaboration and thinking about how do we use this information for future. Can you tell the group a little about the Orion initiatives and, just kind of a glimpse of what we're doing in Colorado and then what impact this has with shared collaboration between other institutions?
Yeah, absolutely. Thanks, Andy. So Orion is kind of a neat program where they've essentially gathered several large academic centers. And, when you look at an Ohio State or an MD Anderson or even us here at Colorado, we all do biobanking. So when we take out cancer, So let's just use colorectal cancer as an example. We'll take out a cancer, we'll send it to pathology, but part of that tumor will be banked, and they're kept in a freezer. And the reason why this is important is because you can then take a look at that tumor and do some studies on it. You can stain for particular proteins, you can do some mutational testing, you can do some genetic testing. And so, these are made up numbers, but what if we had like 50 or 100 tumors here? Maybe we could do a study where we kind of look at 50 tumors, and maybe that might provide some signal of evidence, but that's all we got. If you look at Moffitt or Ohio State, or they all have their kind of 50 or 100 tumors in a particular tumor type. Orion is essentially a centralized system where we can start sharing our biobank, our tissues. And why this is important is that, well, if I were to study kind of a rare tumor, and let's just say patients with colorectal cancer under the age of 40, that's a minority of all the patients that have colorectal cancer in the United States. Maybe I have about 10 samples in patients that are 20 or 30 years old. I can do a study on 10 patients, but boy, that's not a lot to be able to look for a signal of activity. Using Orion and using a combined data bank, of tissues that are, that are annotated with clinical information and maybe even genetic information, instead of 10 tumors, I can collaborate with 10 other universities, and now I have 500 tumors. Well, boy, that's a lot more powerful. And that's a lot more collaborative, and we can share tissue, we can share information, and that's what Orion is. And so you'll start seeing more and more of these programs coming up where, again, nobody should ever live in a silo. The more we're able to work together, I think the faster the rate of research will be. And that's what we're involved with, along with several other institutions.
Thank you. So we've had a couple of really great questions come in, and I know we're running short on time, so I'm going to kind of condense these together. But so when you look at a person's cancer over time, do mutations change as a cancer evolves? And then related to that, is there a way to make a non-MSI high tumor turn into a hypermutated tumor?
Yeah, so great. Those are just phenomenal questions. And the answer is, in some cases, we have clear evidence where a tumor will not have a KRAS mutation. We treat with an EGFR inhibitor. The two that are FDA approved are cetuximab and panitumumab for colorectal cancer. And in a subset of patients, we can start detecting RAS mutations because we've put that pressure on the tumor. And so, yes, these changes can be dynamic. They can also be temporary. Which means that we can see them for about 6-8 weeks and then they disappear. So this is certainly a very dynamic, not a very static environment. Does it happen for all patients? It doesn't, but can it happen? Yes, and we have to be aware of that. This kind of brings into light whether we should be doing liquid biopsies as the technology gets better so that we can monitor these dynamic changes. That is something that obviously is going to require a lot of research, and now we're really kind of talking about the very cutting edge of what we're starting to think about. In regards to the hypermutated tumors, where you have 1,500 mutations versus the not hypermutated tumors, where you have kind of typically 30 to 60, the answer is it's an intriguing question. Can you induce more mutations, and could that be dangerous? Because you're actually causing more mutations? Could it be beneficial because then immunotherapy may work? That is really, really on the kind of forefront of the questions that we're starting to ask. What I believe is that it's not maybe necessarily about the mutations in a tumor, it's about drawing in immunocells, T cells, to where the tumor is. If you can get the T cells there, then maybe we can push them over the edge and get them to start attacking the tumor. It's a great question. It's still very early to answer.
Thank you. I'm going to ask one more question, and then I'll leave it to you for any final thoughts and to conclude today. But just thinking about genetics and how important, this is related to colorectal cancer, is it ever considered about a second-line family member's diagnosis being as important as a first line in terms of genetics? So the example being like a maternal grandmother, and thinking about what we look at as far as genetics go with colorectal cancer.
Yeah, it is. We always talk about first-degree relatives. You're right. The second-degree relatives can start giving us a hint of what could, of how profound or how strong the family history is. So Typically, we look at first-degree relatives with, more carefully, with a kind of a closer eye. But second-degree relatives are important in that, boy, if you have everybody on the maternal side either developing, like a grandmother and an aunt, that they develop colorectal cancer, and some have developed ovarian or endometrial cancer, it certainly heightens your awareness. And this is where we start talking about sending people to our hereditary cancers clinic. And by rule of thumb, when there starts to be a hint of activity, even in second, degree relatives, that's an indication to send them to genetics. If it's a patient under 50, they automatically get sent to genetics.
Thank you. So Dr. Lieu, this has been incredibly helpful. This is wonderful preparation for everything that we're going to be talking about in Colorado at the beginning of November, and then as we move forward, becoming better patient advocates and kind of the terminology we need to think about. So I'll leave it to you for any closing thoughts, and just want to thank you so much for your time.
Yeah, I'll just say thank you guys for taking your time out of your day for this. I hope you found it helpful. I would just say be bold, speak your mind. We definitely need this, and the RATS program is just super exciting. We need people who will advocate for our patients in a way that we simply cannot do for them. We need these in the task forces. It's critical, and I don't want to ever understate the importance of this. And so what you're doing is critical, and thank you for taking the time to do it.
Thank you so much. All right, everyone, take care.